Okay, welcome everyone. We are going to talk about respiratory pathophysiology in the nursing setting. So you'll want to review the anatomic structures of the respiratory system. So we look at the upper airway structures, the nose, the nasopharynx, the mouth, through the trachea. When we have illnesses that affect these upper structures, those are considered upper respiratory infections. Mid structures, we refer to the main bronchus, so things like bronchitis, and then the lower bronchial branching and lung parenchyma, those are lower respiratory infections. So just keep the anatomy in mind as you're learning about these different illnesses. The purpose of the respiratory system and the lungs, of course, is gas exchange. So here you have a diagram of the alveolar capillary membrane encircling an alveolus, and that membrane is a thin barrier where gas can cross. So intake of oxygen gets picked up by your hemoglobin molecules, CO2 is dropped off and released, and that's where that gas exchange happens. So if you have anything like fluid accumulation or mucus plugging, that's going to obstruct any gas exchange there. You can also have things like blood clots on the pulmonary circulation side that block oxygenation and CO2 removal. So inspiration, that's the process of breathing in to acquire oxygen. Most notably, air movement is unidirectional, so coming in, going from an area of high pressure to an area of low pressure. Exhalation or expiration, that's where you're removing carbon dioxide out of the body via the lungs. The diaphragm and intercostal muscles have to relax, the lungs compress, and that increased pressure inside the airways forces air out. So if you had anything like a traumatic brain injury or a spinal nerve injury that's altering innervation to the diaphragm or those muscles, you may not be able to create enough pressure to exhale. The process of diffusion then is when those oxygen and carbon dioxide molecules are exchanged at that ACJ, that alveolar capillary junction. So oxygen is trying to move across the membrane and hitch a ride on your hemoglobin and then move towards the cells in the tissues that need it. Carbon dioxide is trying to escape, and effectiveness of this is going to depend on both partial pressure and solubility of gas, and then the thickness of those membranes. So we do pulmonary function testing to measure a patient's baseline, and then that helps us make adjustments or decisions about people's pulmonary status, for example, with asthmatics or someone with a chronic pulmonary disorder like COPD or emphysema. So tidal volume, that's the amount breathed in and out on a single breath. Normal tidal volume for males is around 500 milliliters. For females, it's around 400. And if we have a patient on a ventilator, we'll dial in and deliver this estimated normal value unless they have a specific pulmonary disease where they are accustomed to taking lower values. So we look again at what that patient's baseline is. If they're having a flare-up or having a difficult time, those values will go down. And then we can adjust medications like bronchodilators or steroids to help them reach optimal function. Total lung capacity, that's the volume of air in the lungs when they are fully inflated. And then residual volume is this little amount of air that's left over after a maximum exhale. And that residual volume is what keeps your alveoli from collapsing. That's a number that we go after when we have someone on like CPAP overnight for sleep apnea so that they don't have alveolar collapse. Ventilation perfusion mismatch or VQ mismatch happens when part of your lung receives oxygen without blood flow, or you have good blood flow without oxygen. This can happen if you have a blocked or obstructed airway, like if someone's choking, or in COPD. Or on the reverse, you could have a blocked blood vessel, like a blood clot in your lung that blocks oxygenation. So in that case, you have good air intake, but the blood flow is not there. Here are some common signs of a pulmonary condition. I would add any change from baseline, because you can have people with asthma or COPD who are stable at baseline, and then there's a change in their condition where they're having increased dyspnea or more tachypnea. So monitoring closely for those changes. Some of the tests that we do if someone's coming in with a pulmonary condition, we use blood gases frequently, at least in my unit, because patients are changing so rapidly. You might be following blood gases multiple times throughout your day, every 1 to 2 hours, every 6 hours, things like that. Pulmonary function tests, those are those little meters where you blow into, you exhale at maximal force or maximal effort, so we can see how much air you're able to exhale from your lungs. Those are great with asthmatics or COPD patients. Pulse oximetry, measures your blood oxygen levels at the capillary level, and then of course, X-rays, CTs, things like that. Okay. When we're getting those blood gas studies, we're looking ultimately at the patient's acid-base balance. So there's this precise equilibrium between acidity and alkalinity in the body. And any imbalance causes disruptions at the enzymatic level within the cell. The lungs are responsible for exchange of oxygen and CO2 at that alveolar capillary membrane level. And then the kidneys are able to eliminate any excess acid by holding on to a base to balance the body. But if you have a condition that obstructs exhalation of CO2, or maybe you have a kidney condition where you're not buffering acid very well, then we have imbalances. So you guys will go into more detail and have more practice with blood gas interpretation next quarter. And then as you get further along in the program, you'll have opportunities to look at this in the clinical setting as well. But you should start to know and recognize alterations. So just knowing that your normal pH is going to be 7.35 to 7.45. If it's less than that, the patient is very acidotic. And so we see that with CO2 accumulation, any condition where there's not good gas exchange. On the alkalotic side, greater than 7.45, we see that if a patient is hyperventilating, for example, or sometimes we've dialed up the respiratory rate too high on a ventilator for a patient that's on mechanical ventilation, and we can overbreathe, breathing too much, exhaling too much CO2, and they get alkalotic. So please know and recognize the normal values for pH, CO2, PaO2, and bicarb. And then if we have time in class, we can practice a little bit. This flow diagram is a great tool to help you see how we break down these different causes of alterations in pulmonary function. So often a patient comes in to see us through the ER or clinic, or whichever way they come and meet us in the healthcare setting. And they have signs and symptoms of a pulmonary disorder, right? Difficulty breathing, they might be cyanotic or what have you. So the first thing that we do is get those blood gases, maybe get a chest x-ray, try to take the story, but we don't always know the cause. And then it takes a little bit of investigative work to sort out what's causing the alteration. So you can see on the left-hand side, alterations in ventilation. The goal with ventilation is exchange or intake of oxygen and exhalation of CO2. And so the ways that that can be blocked or altered, you can have obstruction or blockages of airflow. Examples of that, bronchoconstriction, that's with your asthmatics, or suffocation, or you could add choking. You can also have problems with the mechanics of breathing. Examples of that would be a drug overdose, or you could have nerve damage, like in a cervical spine injury. Okay, and so you can see how that would block airflow and lead to hypoxemia, hypoxia, and hypercapnia. And then on the diffusion end, that's where we're doing the gas exchange at that ACJ. You can have different conditions which impair that ACJ. You could have thickness of that cell barrier with conditions like emphysema or fibrosis. You could have pulmonary edema or infections. And then you could also experience decreased partial pressure of oxygen. And we see that at high altitude or in any condition where there's oxygen deprivation. And that'll block the transfer of oxygen to the circulation and the removal of CO2. Okay, so I think this is a great tool to just kind of break down for you the different ways in which the pulmonary system gets compromised. We further differentiate different pulmonary diseases as obstructive or restrictive. Obstructive disease, you have a blockage or narrowing of the airways, making it difficult for air to flow in and out of the lungs. So some examples of that, COPD, which we'll talk about, asthma, bronchiectasis, and sleep apnea. In restrictive lung disease, the lung tissue itself has become stiff, damaged, or scarred, which restricts the expansion of the lung tissue. You have decreased lung volume and a decrease in the ability to inhale adequately. We see this with interstitial lung disease, pneumonias, lung cancer, any rib anomalies that block that full inhalation, and then neuromuscular diseases. And we also type pulmonary diseases as acute versus chronic. Acute respiratory conditions come on quickly, often caused by obstruction, injury, chemical inhalation, or stroke, and can go on to acute respiratory failure, which can be fatal. Pneumonia would also fall into this category. Chronic respiratory conditions are those long-developing syndromes that require ongoing care, often get worse over time. And often there's not a cure, but the goal is to manage symptoms. So examples of that would be COPD. We are going to start by talking about infections, specifically pneumonia. Pneumonia is an infection causing inflammation around the alveoli. So not in the main bronchus, not in the bronchioles, so not in those larger structures, specifically around those alveoli, and which get inflamed. You have fluid, mucus production, etc., that blocks good oxygenation and ventilation. Most commonly viral and bacterial, and more rarely fungal, are the cause of pneumonia. The spread is through respiratory droplets. And what occurs is that fluid collecting in the alveoli and the interstitial space, which compromises that exchange of oxygen and CO2. Clinical signs of pneumonia: sudden onset fever, chills. So we see lots of illnesses where you have fever and chills, you have a runny nose. That might just be an upper respiratory infection. But when the patient, it progresses to cough, lots of sputum production, fatigue, and then the difficulty breathing. So there's the difference, right? Because you and I can get the cold and flu, we can have a fever and chills, we can have mucus production, but generally we don't have difficulty breathing with that. So if you're having dyspnea, which is that sensation of difficulty in catching your breath that patients report, tachypnea, you might have tachycardia, and then patients might say that they're having pain, pleuritic pain with inhalation. And then on auscultation, you'll hear fluid in the lungs, which we call crackles. Pneumonia can be anywhere from mild to moderate or severe. So you could have a viral pneumonia that keeps you at home, you never need treatment for, but you do have a lot of these clinical signs. And viral pneumonia will get better on its own and go away. But if you have a patient that has any underlying illness that makes fighting an infection more challenging, that can progress to more moderate or severe disease where they then can't exchange oxygen and CO2 and they need to come in for medical care. We diagnose pneumonia ultimately with a chest x-ray. But again, you're going to take that history and physical. You are most definitely going to do a CBC. You might have them cough up some sputum and send that for gram stain and culture. You're also going to do some blood gases to make sure that we're oxygenating okay. Here's a chest x-ray of a patient with pneumonia. So you can see where this arrow is pointing. You have what we call patchy infiltrates. So there's some white fluffiness showing up there in that right upper lobe. And that's pretty indicative of pneumonia. So with pneumonia, the fluid collection is not evenly dispersed. And so we see what we call consolidations or patches of accumulation. You can see in that right lower lobe, it looks like there's good airflow, good oxygenation of that part of the lung. Okay, so it would be different if the lungs were completely whited out. That might not be pneumonia, that might be something else. So this x-ray is pretty telling of what we're looking at. Pneumonia treatment then is to provide oxygen and breathing assistance. So we want to support oxygenation and ventilation until the patient is better. We want to identify the cause and then treat that. If it's viral, often we don't have treatment. We don't have a lot of antivirals that we use in a pneumonia setting. So there it's just supportive treatment until they're better. But if it's bacterial, we can do antibiotics. And we can also offer pulmonary treatments medication-wise that help with oxygenation, like some of your bronchodilators, things like that. We also want to mobilize those pockets of fluid and pus. So deep breathing and cough, we do some percussion to some of those areas to make sure that that fluid is moving. And then mobility. So if they can get up and walk, but if they're sick enough that they're bedbound, we want to make sure that we're turning the patient frequently so that pus and fluid is not pooling or sitting in one specific area. Okay, so let's look at this first case. We have John, age 65, coming in with a 3-day history of worsening cough, shortness of breath, fever, chills, and he reports a productive cough with discolored sputum and fatigue. Okay, let's look at his vital signs. So anything you notice there? The temperature, his pulse ox, 89%. Okay, we would need to know what his baseline blood pressure and heart rate is, but they seem to be elevated. And then on physical exam, decreased breath sounds in the right lower lung field. So there's an asymmetry there. So it tells you that something's going on in that right lower lung. Okay. And you hear crackles. So suspicion with the fever, you're always thinking about something infectious. And then your exam and your vital signs kind of back up that suspicion. So think about some assessment findings that would indicate to you that his condition is worsening. That might be a change in pulse oximetry. That's easy to assess, right? Because it's up on the machine. It tells you. But you want to use your observation and assessment skills. So doing good assessments, frequent assessments of the physical status, you're going to look for retractions, accessory muscles during breathing. You're going to look at capillary refill and those nail beds. You might have more increased pockets of pneumonia. So when you're listening, you might not hear good breath sounds in certain areas, crackles increasing or worsening. And then on the flip side, what assessment findings would indicate that he's doing better? You're going to see improvement in a bunch of these things, right? So it's important to monitor your patient's condition throughout your shift as it's changing. And then, alerting the medical team if it's changing acutely for the worse, you want to intervene. And then if it's improving, that's great. And you can document that. You can set your nursing goals around that for this patient. Like he'll have improvement in feelings of dyspnea, respiratory rate will normalize, things like that. And then in terms of priorities, what will be your priorities? On the last couple weeks, our priorities had been fluid replenishment. We talked about a bunch of cases where the patients were dehydrated or had sepsis and they were losing blood pressure. So in those cases, hydration is really important, right? But in this case, what are your priorities going to be? So you want to improve oxygenation immediately. So whether that's putting on a nasal cannula with oxygen, and that's actually something pretty simple to do. And if you work in an urgent care or emergency room setting, we often have standing orders so that the nurse can just go ahead and do that for anyone with oxygen sats less than normal. But maybe they need more, maybe they need CPAP, or maybe they need you to take over rescue breathing with a ventilator. So priority will be oxygenation. Fluids and hydration is going to be secondary in this situation. And then treating the underlying cause with antibiotics or whatever as we identify the cause. Okay. So here's our patient's chest x-ray. And what are you seeing? So the left lung is nicely expanded. There are nice dark areas of aeration, good airflow. And then on the right upper lobe looks good. But that right lower lobe, see how it's whited out? That's a consolidation that we see with pneumonia. So there's fluid, exudate, what we call pus, mucus trapping, clogging up that lower lung. This patient has a CBC. Looks like the white count is a little elevated. And so he's admitted, we're treating him for his symptoms, and then the sputum culture comes back and it's positive for Streptococcus pneumoniae. So now we can focus, if we had started antibiotics already, we will change or adjust the antibiotics specific for this bacterium. Okay, these two x-rays are not our patient John Doe, but I just wanted to demonstrate to you, sometimes you have the patient arrive with signs and symptoms, you have high suspicion, but then your findings don't match what you suspected. And so you have to stay open-minded and adjust your approach to what's going on. So the x-ray on the left, where there's a lot of white markings, but it's throughout the lungs and it's pretty evenly dispersed. So that's not consistent with pneumonia. Pneumonia, you have pockets of pus in the x-ray. This x-ray could be something else. It could be something like an inhaled irritant, like a chemical, where it was inhaled even distribution of inflammation. Or this could be from something like COPD or emphysema, where there's disease throughout the lungs. Okay, the x-ray on the right is just a normal x-ray. So again, if your patient comes in with fever and difficulty breathing, but then we have a normal x-ray, we have to evaluate other causes. Maybe they've had a pulmonary embolism, a blood clot that's blocking blood flow to the lungs, and that's the cause of breathing. We don't know, so we would have to investigate in that case. So I just wanted to demonstrate that the testing, we don't always know what's going on with the patient at the beginning. We have to do our investigative work, and then sometimes the tests come back and we have to change our approach. Okay, back to John. So we've come up with some nursing diagnoses, and these are not all inclusive. You could come up with a list of probably 20 things that you want to approach for this patient. But these are the ones in the example: ineffective airway clearance related to secretions and inflammation, as evidenced by cough and sputum production. So you're going to create some active action items to match that so that you can help him clear secretions. And that might be chest PT, deep breathe and cough, might be mobilizing secretions through activity. And then impaired gas exchange related to that alveolar consolidation, that right lower lobe consolidation, as evidenced by increased respiratory rate and decreased breath sounds. So you're going to create interventions to improve that as well. And here are the interventions that they came up with. So related to airway management, we're going to do deep breathing exercises. We're going to use that incentive spirometer device to help with deep breathing. We're going to give any prescribed medications. Ensure adequate hydration and nutrition. Fluid intake is directly related to blood circulation, right? And good circulation helps with oxygenation and CO2 removal. So you want to maintain a normal blood pressure through hydration. Monitoring, and then patient education. We want the patient to complete the full course of antibiotics. We want them to know signs and symptoms of worsening conditions so that they come back if this is a discharge teaching plan. And then any lifestyle modifications that we'll go over. can be included there. Okay. So here's our evaluation of the patient, our goals after 72 hours. He should have showed significant improvement. And usually that's just waiting for those antibiotics to kick in and giving supportive care until he's improving. So this patient, his temperature stabilized. He had reduced sputum production, improved SATs, and he was able to go home with follow-up. With discharge teaching, we're going to make recommendations for follow-up care. And then you want to have a plan for how you'll measure the effectiveness. So what would demonstrate successful outcomes? Maybe that's ensuring that he gets his flu shot every season, making sure that he maintains a healthy diet, stays active, things that will improve his quality of life and help ensure that he doesn't get pneumonia again. Okay, we're going to shift gears into COPD. So this is different compared to pneumonia, which is an acute, generally short-term illness that one can recover from fairly quickly with appropriate treatment. COPD, or chronic obstructive pulmonary disease, is a progressive long-term disorder, so defined as a life-threatening disease caused by progressive airway damage, airflow limitation, and difficulty breathing. And this can take many, many years, sometimes decades, to develop. It's associated with structural changes due to chronic inflammation. And so that inflammation over time that doesn't improve is usually in response to a chronic irritant, mostly smoking. But we also see this in people who live in cities with lots of air pollution or other environmental toxins. But it really takes that long-term chronic exposure, and the immune system or inflammatory cascade continues. There's not a break from those irritants. So COPD is actually a big umbrella term, and a bunch of different disorders fall under it. But the most common ones are chronic bronchitis and emphysema. And some people actually would put asthma under this category as well. But there's some disagreement about that, because you can have, you can outgrow your asthma over time, and you can remove allergens and things like that. So there's a little debate, but most commonly chronic bronchitis and emphysema. So some of the key differences in bronchitis and emphysema are the location of where that cellular restructuring and remodeling occurs. In bronchitis, we're talking about the large airways, the trachea, the bronchi, and then the bronchioles. So you've got mucus hypersecretion, inflammation, and airway obstruction, because as that main bronchus and those bronchioles get inflamed, they start to thicken. And so you have a situation where you can inhale in, but then exhalation becomes difficult as you're exhaling against a smaller vessel, and it requires higher pressure to exhale. In emphysema, we're talking about this chronic inflammatory process affecting the bronchioles, the alveolar ducts, and then the alveoli. And we'll look at this as we go through the slides. The hallmarks of this disease includes chronic inflammation, airway remodeling. So here we're talking about remodeling or changing of those actual cellular structures. You end up with thickening of the airway wall and increased smooth muscle mass. So in this diagram, you can see that the picture on the left where you have a normal bronchial tube, and then on the right, you have an inflamed bronchial tube with very, very narrow airspace opportunity. In addition, with COPD, you get loss of elastic recoil. And what that means is your alveoli and bronchioles, the musculature under normal circumstances is very elastic and flexible. We want your alveoli to be able to inflate and deflate like a balloon. But if you lose elasticity there and those alveoli get thickened and hardened, then they're not able to really expand on inhalation and collapse with exhalation. So very difficult time moving air in and out. And that's what causes increased airway resistance. Just think of a narrow tube that you're trying to inflate a balloon through. If you try to inflate a balloon through a skinny, firm straw, it's going to be very difficult. This disease has exacerbations, so flare-ups, times when the disease is worse. And that can just depend on other environmental factors that might be contributing or just your immune system's difficulty in managing the disease. And then ultimately, these patients can end up with respiratory failure. So often COPD or emphysema patients are often home on oxygen. You'll see them out in public with a backpack or a cart that has an oxygen tank. Chronic inflammation is the driver of COPD. So you first have this trigger, which is the inhaled toxins, creating an inflammatory response. And if this is ongoing, like with smoking, or if you grow up in a city that's heavily polluted with environmental toxins, that trigger doesn't go away. So it's this continuous inflammatory cascade. You have your white cells rushing to the area. And the problem with that as an ongoing process is that neutrophils secrete elastase. That's a product that breaks down elastin. Now, elastin is that nice, stretchy, flexy protein that helps the connective tissues in your lungs expand and contract. So imagine this over years and years, you've got reduced ability of those alveoli and those bronchioles to really stretch. This is where we get, firm, inflexible tissue. Oxidative stress and an imbalance in enzymes and proteins is also a key component in COPD. And then you have inflammatory cytokines activated. And remember, they call everyone else to the site. They activate and promote survival of those inflammatory cells in the respiratory tract. So just, again, imagine that this is continuous over years and years and years. And a lot of people that smoke, if they don't quit, they don't remove that toxin. So the airway changes and rebuilds over time. One of the other things that's not reflected in this slide is that the cellular structures change. In this setting, you have increased epithelial cell production, and those bronchial epithelial cells, they're a primary barrier between contaminants in the lungs and the lung tissue. But if you have increased development in those types of cells, you have increased mucus production, and then they actually form a thicker barrier, which further hardens the lung tissue. This slide just reviews oxidative stress and free radicals for you. Free radicals and oxidative stress are part of that inflammatory process and one of the drivers of COPD. So I'll just let you review that topic. Okay, the airway remodeling part of COPD, that airway change, it's progressive and it's not reversible. So those walls of your bronchial tubes become thickened. This narrows the bronchial lumen, so that pathway becomes narrow. You have deposits of extracellular matrix in the subepithelial layer. That's the network of proteins and other molecules that surround and support the cells and tissues. So they're helping those cells actually change and grow. You end up with hypertrophy of the smooth muscle, so increased size, thickening, squamous and mucous cell metaplasia, and ultimately airway wall fibrosis. Fibrosis is a hardening and thickening. So decreased flexibility, non-compliant lung and airway tissue. Throughout this process, you have increased airway resistance. So loss of that flexible elastic recoil in the alveoli and bronchioles, that makes it harder to exhale. The walls between the air sacs are partially or completely damaged, becoming inflamed and thickened, as well as the larger airways becoming inflamed and thickened. Because of those cellular changes, you have more mucus production, so easier to clog. And then again, those fibrotic changes, which means you've got thickened scar tissue. In early or mild disease, the patient may have no recognizable symptoms, although they may get winded with exercise or going up and down stairs. Airflow in and out is 80% of normal. With moderate disease, the patient needs to make frequent stops to catch their breath. They will have coughing, wheezing, and breathlessness. And this is a chronic daily cough. Airflow is significantly reduced, 50 to 79% of normal. And then in severe, shortness of breath worsens. Flare-ups often lead to hospitalization, and airflow is 30 to 50% of normal. And then in very severe, these patients have low oxygen levels. So if you took a blood gas, their PaO2 would be quite low. They would also likely have CO2 elevations chronically. Constant shortness of breath, flare-ups and exacerbations can be life-threatening, and they have less than 30% of normal. So think also about being in a state of hypoxia or hypoxemia where you're chronically deprived of oxygen. It makes it difficult for your other organs to function, and you would be lightheaded, dizzy, having difficulty concentration. Sorry, now I'm having difficulty concentrating. But you understand, chronic hypoxia, so low levels of functioning from a brain perspective, and then you're going to have remodeling in the heart as well from the hypoxia. You'll suffer kidney damage, liver damage over time. Okay, so remember that COPD is that big blanket term or umbrella term that covers all the different disorders. So here's the specific differentiation between bronchitis and emphysema. With bronchitis, we're talking about the bronchi and bronchioles. You've got increased mucus production. So just imagine that mucus clogging bronchioles, which are the smallest structures right before you get to the alveoli. So you've got air trapped inside that can't exhale. and more trouble exhaling than inhaling. So air coming in and then it gets trapped, can't get out. We actually see cases where patients inhale, 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 and those alveoli can get so overfilled and distended that they can actually pop. So residual volume increases. Remember your lung volumes? That residual volume is that leftover volume after exhalation that stays and keeps those alveoli inflated. So in this case, they're hyperinflated or overinflated. In bronchitis, we see hypoxia and hypercarbia. These patients develop a barrel chest, so remodeling, reshaping of the lung because it's a chronic condition. And because they're hypoxic, you will see blue nail beds, so cyanosis. With emphysema, it's not the larger airways that get remodeled, it's the smaller airways and loss of elastin in alveoli, which is pretty significant. Here we have alveolar collapse, so they're deflated, they're flattened, so not good exchange of CO2 there. Oxygen delivery is better than CO2 removal. And these patients are hypercarbic and also have barrel chest, but usually are pink. So not as cyanotic as a bronchitic patient. COPD is diagnosed based on history and symptomatology. We can do X-ray and CT to look at what's going on there. Pulmonary function tests to see what their baseline is, and usually it's pretty diminished. The goals of treatment are to control symptoms, improve quality of life. These patients are often on different bronchodilators and steroids. And they're doing a lot of research around vitamin D as an immune system booster to help these patients. So there's some promising research there. Okay, so we're going to talk about asthma for a couple of slides. Asthma is an intermittent or persistent airway obstruction due to the following four things. A bronchial hyperresponsiveness, so that's reactivity or overreaction to some sort of stimulus, whether that's allergens like pollen or dust mites in a home, for example, or maybe smoke. Could also be cold or hot conditions. Some people get exercise-induced asthma. Running outside in cold weather or even overheating can cause it. And that hyperresponsiveness triggers bronchial constriction, okay? You also have a chronic inflammatory state. So just like with the other diseases, you have this immune system reaction. So your white blood cells coming into the area and all of the consequences of that. Bronchoconstriction, so the muscles throughout the bronchial trunk are squeezing and tightening. And then you have excess mucus production. So if it's in response to dander or allergens, your body's going to create more mucus to try to move those substances up and out of the lungs. So here we have a nice flow diagram of what's happening in an asthma attack. Asthma is always in response to a trigger. In this diagram, that trigger is an allergen, but just know that that can be anything. It could be those cold or hot temperatures outside. It could be a new onset viral infection that's triggering it. It could be smoke in the air, any of those things. So the allergen triggers this initial immune response, releasing histamine, leukotrienes, interleukins, and prostaglandins. Remember, those are your chemical messengers that call the immune system over. Then you have simultaneous bronchospasm, and then this infiltration, this massive wave of inflammatory cells coming into the area. Okay. Then we have airway inflammation, which limits airflow in, edema, epithelial cell injury, and then impaired mucociliary function. All of that cascade contributes to chronic inflammation in the airways. And here you have an image of an unobstructed airway on the left, and then on the right, you have an obstructed airway in the setting of asthma. So you have engorged blood vessels. Why is that? Engorged meaning enlarged. Remember, that's part of that inflammatory response, is to dilate so that you can get cells of the immune system into the damaged area. You have muscle spasm. That's that contraction or hyperresponsiveness. Mucus plugging from increased mucus production. Asthma is a combination of risk of environmental and genetic influences. So if there's someone in your family with a history of asthma, that puts you at increased risk of having asthma. Most asthma is related to allergies and is a result of what we call the allergic cascade. So for most people with the allergic type of asthma, the immune system recognizes that allergen as a foreigner and starts creating IgG in response to that. That's during that early or sensitization phase. And then later, as you continue to get exposure to that, your immune system recognizes that as a foreign substance and starts to react with increasing severity. And then it gets to a point where it's overreacting in response to those environmental factors. Here's a list of some of the triggers on the right: smoke, environmental allergens, pollen, dust mites, cockroaches, fungus, air pollution, and then infections can cause it as well. Some people, like I said, hot and cold temperatures, exercise induced, so lots of triggers. So when you're counseling patients, first taking that history, not all patients will be fully aware, but you do want to ask, like, have you noticed, is there anything that makes it better or worse? Have are there any activities that make it worse? Any environment, like, are you getting are you having asthmatic attacks at work or at school, or is it when you're playing on the soccer field? That kind of thing. You want to take a really good history. Often they're also allergic to other things. They might have eczema, they might have food allergens. So other signs you're looking for that their immune system is triggered or responsive to the environment. So clinical signs that we see with asthma attacks: wheezing. And that's usually a high-pitched sound, and that comes from that airway narrowing pretty moderate to severely, so that you're hearing air trying to get through the main bronchus. Tachypnea, Dyspnea and coughing. Coughing is a reflex to try to open the airways, so these patients will cough out of air hunger. A feeling of chest tightness. They may or may not notice increased sputum production, but these patients have anxiety, and that's notable because it's severe and sudden onset. Whereas your pneumonia patient, your COPD patient, those are kind of slow, broiling, like longer term, at least, difficulty breathing. So they don't come in with acute respiratory distress or signs of impending doom. Like their trouble breathing takes time and they kind of get accustomed to it. Asthma is severe and sudden and induces panic. So diagnostic criteria, history and physical, pulmonary function tests to see what their lung or pulmonary function is like. If they're coming in acutely, you're probably going to do some blood gases. Also not on the slide, you also would probably do a CBC. You want to look at what the white blood cell tests are doing. In the acute care setting, you would not do allergen testing, but you would actually, if you're discharging them, one of the follow-up things would be to go have allergy testing with a specialist and look at what some of the triggers are. And then they can follow those white blood cells and just see how reactive. They can check histamine levels. They can do a bunch of expanded things that we don't do as part of our routine care. Pulse oximetry. We don't usually do a chest x-ray to look at asthma. The chest x-ray would be mostly clear. The lungs are otherwise normal, the lung tissue. So it's not routine for an asthma attack, but you might do a chest x-ray to rule out other things and make sure you're not looking at something else that's blocking the airway. And then spirometry practice would be another thing as part of that's one of the pulmonary function tests, so we would include that here. So one of the most important things with asthma is to control those environmental triggers. And we do see a lot of children with asthma, so it's a great effort on the parents' part to like keep the child's linens and curtains clean, keep the carpet clean. Sometimes a trigger is natural fibers in the rugs. So like if you have a real wool rug versus synthetic, that can be a trigger. Stuffed animals. We ask kids with allergies and asthma to not have stuffed animals in bed with them or to wash them frequently. We ask parents to smoke outside if they're going to smoke. And then just recognizing like we can't control every environment. If they're in the school setting, if something's triggering them there, that's going to be more difficult. We use medications for asthma treatment, inhalers, a couple different types. There's a bronchodilator, which is for immediate use to open up those airways. And then for long-term use, if the child's having a lot of attacks, I should say child or adult, steroids can be used. We have inhaled or oral steroids. We don't want a patient on steroids for long-term because it does suppress your immune system, but we want to make sure that we get through exacerbations. So some patients, if a trigger is environmental pollen season, they might need to be on a steroid throughout pollen season and then be off in the winter. So we just kind of tailor what's going to work best for them. And then we give the patient something called an action plan. I have that on the next slide. So because the bronchodilator is an emergency medicine for flare-ups, we have the patients track how often they're using that medication, how much, how many puffs, how often, and when. And so you might have a patient who's in the green zone, whose breathing is good. They don't have a cough or wheeze. They're able to sleep through the night. It's not interfering with daily function. Maybe they've used it only once this month, and no flare-ups in between. So that says green. Green means go, your asthma's under control. In the yellow zone, we have caution. Maybe the patient has oncoming signs of a cold, or they've been exposed to the trigger more frequently. They might be coughing a little bit more. They might be noticing some chest tightness. They might be mildly wheezing. And they're going to document how frequently they're using those inhalers. And here in the yellow zone, we ask them to call the provider to just discuss. So if it's just a cold and they're just checking in with us, we might say, okay, great. Keep using your inhaler, document how frequently you're using it. Check in with us in a day or two and we'll see how you're going, because, the cold gets a little bit worse on day 3, but by day 5, it's a little bit better. So we hope that this patient will recover fairly quickly. If, on the other hand, we don't know why they're having, say it's not a cold and we don't know why they're having exacerbation, that might take a little more investigative work to find out what's changed in their environment. Okay, and then red is the danger zone. The medicine is not helping. They're breathing hard and fast. They're having trouble speaking. They're short of breath. So this patient in the red zone needs to come in immediately and be evaluated. And some of the things that we can do in emergency care is give nebulized inhalers. We can give some racemic epi. Epinephrine is that fight or flight chemical that we make in our bodies, but we can also give it synthetically, and that'll help give immediate relief. But we might also need to start some IV steroids, some high dose, to get things under control. Okay, sometimes these patients need oxygen and other things as well, just getting over this exacerbation period. And having this asthma action plan is a really great guide for, families with young children who are new to asthma, so that they have a safety plan and know when they need to be seen, when to go in. These action plans also go to the school setting for the school nurse. Okay, so let's look at a little case study. This is Sarah. She's 8. She was diagnosed with asthma at age 5. She does have seasonal allergies, has never been hospitalized. So she has a couple medications. She's on albuterol as needed, and that's your quick-acting bronchodilator. And then she's on daily low-dose inhaled corticosteroid. Okay, so she's brought to the peds ED by her mom due to increased wheezing, shortness of breath, and coughing, which has worsened over the last 24 hours. Her mother notes that she's been exposed to dust from home renovations and has also been playing outside in high pollen conditions. Okay, so here's a look at her vital signs. So a normal temperature, so not something infectious. We've got her pulse, respiratory rate, and her SATs. So she seems to be in a little bit of distress. She's using accessory muscles with breathing. She does have a wheeze, and she's mildly cyanotic. So we do some pulmonary function testing with her, and she is at 50% of her personal best with peak expiratory flow. So in this case, We have documented her best peak flow rates, and she's only at half of that. So this is very concerning. We have a chest x-ray, which looks clear and normal. And then we have a blood gas. Looks like the pH is a little acidotic. Her PaO2 is a little down. She's got a little CO2 retention. So not doing well from a breathing perspective. Her O2 and CO2 are out of balance. Okay, what if her x-ray looked like this? Sometimes they push the wrong x-ray to us. So look, this is not her. This is Joe Smith. He's 2. And it looks like he swallowed a coin or a battery or something, which is causing a blockage or obstruction in his trachea. So an obstruction can also come in looking like asthma because it's acute onset, struggling to breathe, use of accessory muscles. So sometimes an x-ray is helpful to rule in or rule out what we suspect is going on. Okay, so part of our assessment, what key assessment findings would indicate worsening of her asthma? And what are you going to prioritize? So I think we saw those assessment findings with her vital signs and her work of breathing. But what are we going to prioritize? So we need to get her breathing and exchanging O2 and CO2 right away. So of course, I think you'll think, oh yeah, put oxygen on her, but that's going to add supplement, but it's not going to treat the source. So it's those rapid bronchodilators and maybe a racemic epi treatment to really open up those airways. And then, supplemental oxygen can be secondary. Okay, intervention rationale. Why is it important to administer the bronchodilator promptly? And then what can be the potential consequence of delaying this treatment? So if you don't give the bronchodilator, you could bronchospasm down and have an immediate airway emergency. So if this happens at home with someone, it could be a life-threatening situation. Here are some nursing diagnoses we've come up with. Ineffective airway clearance related to bronchoconstriction and mucus production, as evidenced by wheezing and coughing, and then impaired gas exchange. So we're going to come up with interventions to match those. And here we go, several interventions. So immediate airway management, bronchodilators. Monitor response to medication and reassess respiratory status frequently, probably, every 15 minutes. If this is a patient you probably wouldn't leave alone. You're going to, stay with and assess how things are going. Provide oxygen. And backing up to airway management, we'll start those steroids probably in a case like this, but the steroids take a day or two to really take effect. So as important as they are, that's not going to give you an immediate response. Okay, education and support, identifying triggers and trigger avoidance, review proper inhaler technique. Sometimes we actually find patients are using the wrong medication for rescue. If they've got a bunch of different kinds of inhalers, they are color coded so that which one is for emergency or not, but sometimes they can get mixed up. And then monitoring and reassessment, frequent vital signs, and just tracking the effectiveness of the interventions is important. Okay, so after 2 hours of treatment in our ED, her wheezing has decreased significantly. Her oxygen saturation is now normal. We're going to redo those pulmonary function tests, and her peak expiratory flow has increased quite a bit. And she is stable to go. So she's discharged with the asthma action plan. We're going to emphasize importance of regular medication use, avoidance of triggers, and you do want them to follow up with the pediatrician in a day or two just to see how things are going. Did that relieve things, or are we continuing to have more triggers? So asthma, because it can be lifelong, and it can have periods where it flares up and periods where it's under good control. Family education is key to managing and making sure that the patient is healthy and able to do activities of daily living. Trigger identification also is critical. So making sure that exposures are minimized. So for this patient who was triggered outside by both pollen season and exposure to dust, you might have to write a note to the school and say, like, she needs to have inside recess for a time until her asthma is doing better. So it can be a bit restrictive from that perspective, but we want to make sure that the immune system calms down. Okay, acute respiratory distress syndrome, or ARDS, is a life-threatening lung injury that's often caused by sepsis, pneumonia. We saw it with COVID-19. And that happens when lung swelling causes fluid to build up in the alveoli in the lungs. This is more of a diffuse everywhere type of injury, whereas pneumonia was in different pockets. So the alveoli have a protective membrane, but when that lung swelling occurs, it damages the membrane and you have fluid leaking into the air sac, normally where you would be inhaling oxygen. We'll look at pictures of this. So here in phases 1 and 2, you have the beginning of your immune response. This is an alveoli or alveolus, and it's lined by that alveolar capillary membrane. You've got red blood cells floating around, picking up oxygen, dropping off CO2. But with the infection, you have this histamine response, you have the increased capillary permeability, remember, and then fluid starts to shift into the interstitial space. As the disease progresses, you have continued capillary permeability, and then you have leaking of protein with the fluid into that airway space. Okay, as that alveoli fills up with fluid, it damages the surfactant production in the alveolar wall. And then you have alveoli collapse and obviously impaired gas exchange. So the alveoli is full of fluid. There's no way that oxygen can come in and CO2 can get out. There's a rapid progression from that lung injury, whether it's pneumonia or sepsis or whatever's going on, to acute respiratory distress within 24 to 48 hours. You have severe acute inflammation and pulmonary edema. And we differentiate this type of pulmonary edema. It's not from fluid overload or impaired cardiac function. It's pulmonary, infectious, inflammatory in origin. This disease has a high mortality rate and often from multisystem organ failure if untreated, and sometimes even with treated. So just again, imagine your alveoli are filled with fluid, so there's no gas exchange. So the patient is in a severe hypoxic state and becomes very, very acidotic, which impacts the other organs. So most common causes of ARDS, sepsis, severe pneumonia, and then we saw this a lot during COVID-19. Again, it's because of that inflammatory response to the infection, that increased capillary permeability. Remember, there's vasodilation, and then you have movement of these substances across the capillary. So clinical manifestations, tachypnea, dyspnea, retractions, crackles throughout because of even distribution of fluid accumulation. Restlessness and anxiety is common. And usually these patients are already critically ill, whether with pneumonia or sepsis, or they have some underlying illness or metabolic syndrome. So treatments for ARDS, because these patients can go into complete respiratory and then cardiopulmonary failure. Oxygen, obviously, mechanical ventilation to take over rescue breathing. Something called ECMO, which is the most extreme of the life support machines that we have, which can takes out your blood, oxygenates it, removes carbon dioxide, and then replaces with fresh blood or oxygenated blood. Prone positioning helped for some patients during COVID with oxygenating the lungs. And then a careful fluid balance. You don't want to over or under hydrate, but you want to give perfectly adequate circulatory support. And then a whole bunch of medications. Pain medication. We don't want the patient to get agitated because they're already hypoxic, and that can worsen that. Bronchodilators, surfactant replacement, thrombolytics as needed, but these patients are critically ill and require a lot of emergency support and, again, high mortality rate, so low chance of survival after this. So that's the end of the disease-specific topics. I know it's a lot. You should be able to recognize and differentiate between those acute, short time limiting disorders like pneumonia, which is largely treatable, or viral pneumonia, which just is supportive care and it goes away on its own once the virus, the normal course of the virus has passed. Asthma, which can have acute exacerbations, but is a chronic condition. COPD, which are chronic and life-limiting conditions. So recognizing and understanding the differences of all of these is really important going forward. And then I just have a couple of takeaways. So there's lots of common symptoms, right? Shortness of breath, coughing, congestion, use of accessory muscles, chest pain, but there are fine differences in the different disorders that help you narrow in on what is going on with the patient. Assessment techniques have to be good. The patient should be positioned appropriately, and you want to use auscultation, palpation, and percussion. Trauma-informed approach is essential, especially when you're having patients undress. So just taking special consideration into that. Health promotion is important here, especially with our patients with chronic conditions where you want to do a lot of health counseling and health promotion so that they have ultimately an improved quality of life. And then you need to be able to recognize those signs of acute respiratory failure, what's included there. All of this is interconnected. So the respiratory system, it's important for oxygenation, ventilation, and acid-base balance. So this system is really important in delivering oxygen to the rest of our body. And therefore, it's interconnected with those other systems, right? If our respiratory system fails, ultimately, those other organs are going to suffer from hypoxemia. Okay, so that's all we have for this week. I hope you guys have a great week, and I will see you in class.